Hello.
Yeah, just a minute.
Yeah, no problem. Even I cannot get this thing to go on to full screen.
Now we are live on the YouTube. So when you say we I think there is a problem with your connection. Yeah. Yes. We can
I
see.
think it's more likely the problem with the laptop, because even when I was not online, it started giving me trouble yesterday night. But I mean, I couldn't call for help yesterday night. It was like,
I think whatever way we can have, we'll have it.
right.
So
Okay.
yeah, we start. So good morning, friends. Welcome back to Sutter Club morning meeting. Sorry for the little delay because of technical glitch. It's a pleasure to introduce Dr. Sirish Gunn from Nasik. He is an otorhinolaryngology specialist, and he is alum of BJMC Pune. He is operating faculty at several national and international courses. He has to his credit several orations and lectures at national international conferences, several publications at national and international levels. His areas of interest are silendoscopy, endoscopic sinus surgery, and otology. Of course, he has won several awards and involved in some social activities also. In fact, his CV is quite not only lengthy but very interesting also. Because of the time constraint, I'll not go through all. Let us listen to him talking about silendoscopy, what, why, and so over to Dr. Shirish. You have still about 40 minutes to talk, and we'll leave 5-10 minutes for interaction.
Right.
So over to you, Dr. Shirish.
Thank you, Dr. Satish Pandya and Dr. Nene, whom I have seen as a young child. I've seen her practicing doctor since I was a small child. My only regret is that this meeting is on Zoom, because otherwise I could have personally come to Baroda, which is one of my favorite cities. I've spent a lot of my summers there, as my mother hails from Baroda.
Wow.
So let's see what exactly is silendoscopy. So as I said, this is my alma mater. Without this institute, I would not have been where I am today. This is our ancestral home in Baroda, and I've spent lovely days here, and I have lovely memories of Badamdi Bagh, Kamati Bagh, and the planetarium, the toy train, everything. I mean, I can name quite a few places. Now, what exactly is silendoscopy? It's a technique where we explore the salivary gland duct system using a miniature endoscope, which is introduced through the natural opening of the duct, which we call the papilla. Now, the question is, why silendoscopy? I mean, we didn't have silendoscopy a few years back, so why silendoscopy today? And my expression is generally this, and my answer is, why not? I mean, it's logical. If there is an obstruction, then remove the obstruction. So as you can see on the left side, you can see there's an obstruction, a stone causing obstruction, or sometimes you can see a narrowing in the duct. So this is a stricture, this is a stone. And as you can see, Mahatma Gandhi foretold this for nearly everything that comes new. Is first they will ignore you, then they will laugh at you, then they will fight you, and then you will win. So you have to go through all these steps to establish a new procedure. And this is how I did it. And this is what we do when we learn new things. From I won't do it to yes, I did it. That's the way to go. Now, how to do silendoscopy? Now, training is a must because this is done in a field which has no bony landmarks, no fixed landmarks. The learning curve is shallow because it takes a lot of time for us to unlearn those things that we have learned and then get onto a new field. Now, we have training facilities available in CMAST or IMAST, as it is called in Mumbai. We give personal trainings also. And obviously, an open mind is required to unlearn our past training. These are a few pictures from CMAST, also from the salivary gland course at Geneva. If you look at the history, it all began around 1985 when the first fiber optic fiber was introduced into the duct, and then the scopes went on modifying. But clinically, it started picking up in 1995, and it reached India about 2003, 2004. If you look, Europe has been practicing it for 3 decades. Indian scenario dates back to 2 decades, and my own experience is just short of 600 cases until now. I've had the good luck to be able to contribute to this first hands-on book from Geneva. And also now my work is mentioned in Love and Belly, the 28th edition. What do we use? The instruments. So basically the one on top is called the modular sialendoscope. You can see just an optic fiber, but this optic fiber is encased in steel. And the entire optic fiber now goes back. This is where the camera attaches. This is the light source, like in any other endoscope. So though this is a flexible scope, the rigid end is the working end. So it cannot bend like a bronchoscope. That is something we have to remember. Also remember one thing, it being a fiber scope and it has about only 1,000 fibers, the images are not as good as you see in other endoscopes, which have thousands of, lakhs of fibers. The scope below is called the all-in-one because you can see everything is built into this. This is the fiber optic and the camera end. This is the light source. This is the instrument passing through the instrument channel, and this is the irrigation channel. We also have to use salivary probes because remember the salivary papilla is about 0.5 millimeter in diameter in its natural state. So you cannot have anything going inside unless and until you dilate it. So these are various types of fiber dilators or salivary probes that we use. I'll show you the procedure as we proceed. These are the various baskets, the 3-wire, 4-wire, with tip, without tip, and then various handles to it. How do I perform the surgery? So in my OR, the patient is lying on the OT table. I'm on the right end of the patient. The instrument trolley is here. My assistant is here. The microscope that we require for the initial dilatation of the papilla is here. The video trolley on which we see the image of the endoscope, and the anesthesia team is here. Now remember, the assistant also has to be able to see the video trolley. That's why this is the arrangement in my OR. This is the actual setup. You can see he is also watching the screen as I am watching the screen doing the sialendoscopy. What symptoms and signs do we expect? So a patient who comes to my clinic with recurrent swelling of the salivary glands, generally associated with food intake, has pain, sometimes complains of pus, foul saliva discharge, and fever, is generally a case of acute obstructive salivary gland disorder. What signs do I look for? Is hypertrophied gland, a nodular surface, sometimes a palpable stone, especially in the floor of mouth for the submandibular duct, a tender parotid duct. If you clench the teeth, tense up the masseter, and roll your finger over the anterior border of it, you will be able to palpate the duct normally. If it is tender, it tells me that the gland is inflamed. And pus discharge through the papilla. As you can see in this video, this was a case where the other side was being performed, and this side had pus coming out. So you can see the intubation done. Okay, the video hasn't played completely. Let me shift on to the next slide, please. How do we classify the obstructions in salivary glands? So they can be luminal obstructions, that is a sialolith, or a foreign body. And a foreign body can be inanimate or animate. And luminal narrowing, as I said, a stricture. The lumen itself has narrowed down. So if you look at sialolithiasis, which is a intraluminal obstruction, you will find a lot of stones. These are a few representative stones that I have seen. There are inanimate and animate foreign bodies. Hopefully the videos will play and I will show you all of that. What is stricture? I mean, it is basically the process of narrowing of the duct as well as the description of this. In this picture here, you can see the lumen is wide here and suddenly it narrows down to a small diameter. So this is a stricture. And classically also seen here in this classical sialogram. Now, what are the causes of this thing? There are entities called as juvenile recurrent parotitis, kids coming with recurrent parotitis, falsely labeled as recurrent mumps. There is no such thing called as recurrent mumps. If you have had mumps once, you are immune for life. So remember, recurrent parotitis in the pediatric age group has to be seen by a specialist. There are also cases of adult recurrent parotitis, most of the times autoimmune, sialadenitis, sialadenosis, Sjogren's syndrome, radiation-induced sialadenitis, radioiodine-induced sialadenitis, sialoceles. So these are all where we find strictures. What contraindications? And by contraindications, I mean contraindications as of today, because we have seen in every field contraindications which were existing about 10 years back are no longer contraindications. So as the field progresses, these contraindications become, some of them turn into indications. So obviously acute sialadenitis, because there is a lot of pus draining out. Let's see if the video plays here. If the pus is draining out, you really cannot see inside, because as I will go, I'll tell you that we need to irrigate the ducts to keep them patent enough for our scope to go in and have a vision. So this endoscopy is an underwater endoscopy. So the current limitations would be large sialoliths, but these are like, we are overcoming this through combined approaches, which I will be talking about. Intraglandular sialoliths. Now there is something called as, sometimes ultrasonologists refer to the stone as an intraglandular one. So now there is nothing called as an intraglandular or intraparenchymal stone. The stone is in the intraparenchymal part of the submandibular or the parotid duct. So the stone itself is in the duct, but the duct is inside the parenchyma. So it might look like an intraparenchymal. Tight strictures is strictures which we cannot dilate silendoscopically using scopes or balloons or bougies. Then we may have to do a combined approach. What is the incidence? If you look at salivary gland disorders in all, 80% of them, that is a major chunk of that is obstructive. Only 20% is benign, is space occupying lesions. And we all know the rule of 80-20 in the salivary glands. So 20% of all space occupying lesions are malignant, 80% are benign. So we will be able to deal this entire red sector using silendoscopy. There was a study done by Professor P.P. Singh in Delhi, and the incidence was 1 stone and 1 stricture per 20,000 population in India. So if India's population is about 1.2 billion, we have a caseload of 1,20,000 cases per year, and the cases which have not been treated, so they will be added on. Nashik has a population of about 6.1 million, and Nashik district, which means 600 cases per year. What investigations do we do? Like most of the times people will come with an X-ray, but generally we do not advise X-rays now. Ultrasound is the primary go-to investigation because it provides us with a lot of information. And if you have a good ultrasonologist trained in head and neck, you'll get a lot of information regarding where the stone is, the diameter of the duct, the distance between the stone and the papilla, the stone and the hilum, and a lot more. Silography, conventional silography, as you can see here, is something which we now do not recommend because we have an alternative. The thing is, not many radiologists do silography, and it's difficult to cannulate the papilla, and to expect a radiologist to do it without magnification is something which is asking for too much. Also, sometimes if the papilla has been traumatized by the radiologist, then our chance of doing a silendoscopy reduces. If we find a stone, we do a CT scan. We can do an MR silography when we find strictures. This video which is playing at the bottom is about MR silography. So you can see stricture at the papilla, the entire enlarged duct system, and the proximal ducts, which are also enlarged into the parenchyma. And then we do lab investigations for general anesthesia. To my ultrasonologist, I send these 2 pictures always so that they can mark the stone, because in description, sometimes we can just miss out on something. The proximal distal can be misleading for someone because generally people tend to call this end, the papillary end, as the proximal end, but that's the distal end, because the saliva flows from the hilum towards the papilla. So the hilum becomes the proximal end and this becomes the distal end. Hence, I send them this picture and ask them to mark their findings on these pictures. This is a simple line diagram for the parotid. This is a simple line diagram for the submandibular gland. So how do I deal with a patient who is in my clinic complaining of salivary gland obstruction? So this is a symptomatic patient. I'll get an ultrasound done. At the end of the ultrasound, I get two informations. There is a stone or there is no stone. So if there is a stone, that's fine. Then we go in and do a silendoscopy. If there is no stone, what does that mean? It means there is a stone. There could be a stone which is less than 3 millimeters, but with newer machines, we are able to detect even smaller stones. There could be a stricture, or the stone has been missed because the duct has not been followed right up to the papilla. So once I have this information, I will go in and do a silendoscopy. If there is a stone, remove the stone. If there is a stricture, dilate the stricture. If there is a discrepancy that the ultrasound showed stone, but I couldn't find a stone, or there was a stricture on ultrasound and I couldn't see a stricture, then I go in and do a CT scan if the stone is suspected, or an MR silography, and then we can repeat the procedure. But sometimes we now do these investigations before we do the therapeutic silendoscopy. In anesthesia, we can do it under local anesthesia or general anesthesia. More likely nowadays, I'm doing cases under general anesthesia. What has to be emphasized is we have to avoid preoperative atropine or glycopyrrolate, because that dries up the saliva, and your saliva is our friend. We want the duct to be secreting the saliva so that the duct is patent and we can see better. Dr. Pandya, at this point, I think I'm going to just change my presentation. So just bear with me for a minute and I'll get back to you.
Yeah, no problem.
Right. I'm just shifting to another presentation because the further these things are here. Is my presentation now visible?
Yes, yes.
Okay. Is it on full screen mode? Not yet.
It's not on full screen.
Okay. Just we'll wait just for a moment. It took time last time.
Yes, yes.
Yeah.
Yes, now it is.
So we continue further. So how do we do the procedure? is just a moment. Yeah. I think the lag.
Yeah, it's taking time for slides to check.
Okay. So we dilate the papilla, and then I think the papilla dilatation will come in the next video. This slide seems to have skipped. And then we pass in a basket through the instrument channel of the scope. You can see this basket with the guide wires deployed. It's like a urology basket. It's called a Dormia basket, specially made for the salivary gland. And you can see this basket is used to trap the stone. And then once the stone is trapped, you get it out. But remember, in this, the scope, the entire diameter of the scope is less than 2 millimeters. So a stone cannot be pulled out through the scope. The instrument channel obviously will be half the size of the scope. So what we do is we draw the entire assembly out. Okay, the scope and the stone in the basket, entire thing is withdrawn out. So you can see a floating stone. Are you able to see any sound? So this is a floating stone which was causing obstruction, and sometimes people tend to incise the floor of the mouth. But you can see they generally sometimes lose the stone, because see what happens in this video. I have deployed the basket. I'm trying to catch the stone. And remember, my assistant is irrigating. So when the assistant is irrigating, then only I can see the stone. And oops, the stone went inside through that small opening, that stricture. So I had to follow in through that. Now, if you don't have an endoscope, you'll never be able to do this. And once I found out the stone deep inside, I trapped it and I got it out. So stricture dilatation, you look at this part, you see the duct is generally avascular or hypovascular. You can see this is the green guide wire, which is 0.6 millimeter. That is the diameter that is available at that moment. That is the duct diameter, about 0.6 to 0.7 millimeters. So I pass the guide wire, I pass in my scope along the guide wire. The scope has a beveled end, and then that dilates the stricture. We can use balloons, and I think I'll just, because these videos are not playing the way they are supposed to, you can see this is the dilated part of the stricture. I've gone into the duct, which is proximal, quite dilated. And you can see this part, which is rough, is the dilated part of the duct. And once we dilate the stricture, it gives good symptomatic relief. So I'm going to skip this. I'm just going to move to this chart, which says, say, about till 12th of October 2022, I had done 270 cases of parotid and 268 cases of submandibular. As you can see, sialoliths are less in parotid, more in submandibular, as the books would suggest. Strictures are more in parotid and less in strictures. And I had to excise only one submandibular gland. So out of these 268 glands which have been saved, 267 have been saved out of 267. Otherwise, all of these glands would have been excised. So that's the huge impact of sialendoscopy. And for parotid, I don't think people do parotidectomies for inflammatory conditions, for obstructive conditions. It's basically because the facial nerve runs through the parotid, and there's a huge risk of facial palsy if you're doing parotid in an inflammatory condition. I remember I was talking to Dr. Temtan Udwadia, the father of laparoscopic surgery in India. And he said, yeah, you make a very valid point, because just because there's a facial nerve in the parotid and the submandibular doesn't have equivalent nerve running through the gland, that's why people excise the submandibular gland so easily. And he said one thing which has stuck with me for life. He says, ease of surgery can never be an indication for surgery. So what do we do in cases where the stone is large? We cannot really drag it out through the papilla. So we do something called as combined approach. This is the endoscopy being done. There's the stone partially visible. These videos are playing funny. So then once we have trapped it, then we dissect the floor of the mouth. This is the dissection happening. That's the lingual nerve, which is identified and retracted. These are the molars, the mandibular molars. That's the lingual nerve. This was where the stone was. It suddenly has jumped. This video has jumped. And then we do a check scopy. Confirm that we have removed all the stones. We have dilated the strictures. I mean, all this is not possible if you don't have a scopy. And then we put a guide wire. That's the green guide wire going in. And we put a stent over the guide wire, anchor the stent to the floor of the mouth, and we come out. And the stent extrudes by about 5th to 10th day. By that time, the tissues have healed. So that's how we deal with large stones for the submandibular gland. So if you look at my experience, it's like internal combined is about 120, purely silendoscopic 89, because purely silendoscopic stone removal will be about stones less than 4 millimeter in size. Now, parotid sialoliths, again, you can do simple pure silendoscopy when they are small. If they are large, then we do an internal combined approach if they are approachable from the oral cavity. If not, then an external one. So this is how we dilate the papilla. I don't know why the videos are jumping. Once the stone is identified and in the basket, we dissect out as a C-shaped. We remove the stone. Then we do a check scopy, see that we are in the duct, that's the hilum. We pass a guide wire, a stent. The stent goes in and we close the incision. That is the end of the surgery. The gland is preserved. This is post-op day 19, and this is stent removed on post-op day 19. In the parotid, we generally tend to keep the stent for about 3 weeks. We can also do an external combined approach, the classical parotid incision, and we can keep the scope inside, eliminate where the stone is with the help of a scope, and then go dissect directly onto that. That way, our dissection is minimal. We have removed the stone. The scope is passed into the proximal ductal system. Check that there is nothing abnormal. We pass a guide wire through it, and then a stent, and this is also closed in layers. So if you look at parotid stones, purely silendoscopic, quite a few of them, 32, internal combined 13, and external combined 13. So that is how we are into the profession of preserving functioning organs. Now, always there has been, when I keep on giving these talks, especially to general surgeons, to people who are not practicing silendoscopy, they say, oh, I mean, if there is a stone in the gland is non-functional. And I reply that every gland that is lying in a kidney tray is non-functional. You cannot prove. Once you have removed it, you cannot prove whether it was functioning or not. So this is an ultrasound. You can see preoperative 10th of November. You can see a stone, and you can see the post shadow effect. You can see the parenchyma, the echogenicity of the parenchyma. And this is the post-operative phase. The stone is now removed. You can see the echogenicity has changed from this to this. And let's see what, if we compare it with the other side. So this is the right one. This is the left one. This one is what we were operating. Now, if you look 14 days post-op, both these glands are identical in their echogenicity. So something which was this stage has reverted to this, which is the same as normal on the other side. So on removal of obstruction, function is restored. So remember that we should not be in a hurry to remove a functioning organ. And what else can we do? Acute parotitis, which is not responding to conservative treatment, we can do, rarely we can do, but with a lot of caution, endoscopy, we can deal with parotid megaducts. So this is acute parotitis. This is the dilator into the right parotid papilla. You can see pus coming out. And then we go in and do this case. It's difficult for the surgeon, more so for the patient rather than the patient, because there's a lot of inflammation. The tissues are softer. There is a lot of pus, and visibility is not as good. As you can see, this visibility is not very good, but then sometimes if it is not responding, we have to deal with acute parotitis. Parotid megaduct is a duct which is blown up into a big one. As you can see, we have gone in. If you look at the diameter of this guide wire and the diameter of this thing, you will see it's a big duct. Obviously, there is a distal stricture which we have dilated. And as these strictures are autoimmune in nature, what we are doing is we are treating the effect of the autoimmune process and not the cause of the autoimmune process. So we tell the patients that your autoimmune disorder will have to be treated, and there are chances of recurrence, because if the autoimmune process flares up, it can further fibrose the duct that we have already dilated. So that's dealing with parotid megaducts. We find funny cases around, like the duct had dilated right before the hilum because of a stricture here, and you can see this is the guide wire, this is another guide wire. You can see if this is 0.4 millimeter, this guide wire, you can see this is nearly 3 centimeters in diameter. And you can see multiple tributaries here. And then we go into the other part. This one is the other bifurcation of the duct. You can see a carina-like structure, the guide wire now going into this side. And you can see multiple tributaries coming into this part of the duct also. What else can we do? Tongue tie surgery leading to fibrosis of submandibular papilla. The patient was advised gland excision. We did a neopapilla creation. I will show you that. Stone in duct remnant after submandibular gland excision for stone. This happens quite a few times because the entire duct cannot be removed. And if not checked properly, the stone remains, the patient remains symptomatic. So that could be there. There could be foreign bodies, and I will talk about full stones also. So tongue tie neofibrosis, neopapilla. After tongue tie, about 6 months later, this patient had obstructive disorder of the salivary gland. So I tried going in. This is the probe. It is not going in. I tried to do a endoscopy, not very convincing. I dissected the floor of mouth, dissected the duct, incised onto the duct, and did a check scopy, made sure that I was inside the duct, passed a guide wire and a stent, and created a neopapilla just posterior to the papilla. So this was the neopapilla that was created. And thus one functioning organ which would have been otherwise excised has been saved. This is a video. Now you see this duct doesn't look healthy because there is no functioning gland behind it, but you can still find a stone there. And that stone was still making the patient cause pain and foul discharge because that was the stone in the remnant duct. So these cases also we keep on handling. It's very difficult to explain to the patient that why I am having the same problem for which the gland was excised. So just be careful about excising glands. So this was again a foreign body causing recurrent parotitis. The video is stuck. I think, what kind of foreign bodies do we get? We get generally aniseeds. You can see now you can see this foreign body. It is shaped. I mean, the video is just jumping. It just jumped over the foreign body removal part, and it was an aniseed. It looks different because it has a stem and a body kind of thing. So generally on ultrasound reported as soft stones because they do not have as much calcification. Now this, you can see two foreign bodies here, also reported as soft stone. I went in, when I was removing, unfortunately the videos are not playing very well, otherwise you can see very clearly. I was using a 3-wire basket, and as I was withdrawing the caught foreign body, I could see 4 wires. So I was wondering what's happening. I mean, if a 3-wire basket has broken, then it doesn't help in catching, but it had caught the foreign body. Also, as I was withdrawing the foreign body, I could make out there were some appendages attached to the foreign body. And we finally managed to remove this. Old lady had 3 acute attacks of parotitis in the last month. And you will be surprised. I don't know if it comes down to the last, it can show you the last picture. Guess this insect was what we removed. So you could see 2 parts of the body, and the wire that I was seeing was probably one of these appendages. So this is the only documented case of an insect causing parotitis. I have not seen any case in the world ever. Now, full stone is this patient came in with a CT scan showing stones in the parotid region, getting cheek swelling. I did a silendoscopy. There was nothing inside, no stone, and stones as big as this could not be missed. So fortunately, one of the stones was palpable. So I did an internal combined approach. I removed, there was a lot of bleeding. I removed these 3 stones. And as I was using a radio frequency to dissect, I destroyed some portion of the stone. So I thought that was funny. I opened that stone and it turned out to be a calcified phlebolith. I went back and said, how was I fooled by this picture? And I went back to the radiology journals and found out that when they do a KUB, if they find a stone with a radiolucent center, then that definitely is not a ureteric calculus. It's a calcified phlebolith. And here you see all 3 had radiolucent centers. So if you have a stone with a radiolucent center, it is most likely a phlebolith which is calcified in the venous malformation around that area. So that was a great learning for me. I hope nobody else ends up doing this now that I've told you. Now, what else can we do? Facial trauma leading to drug transaction can be handled, treating post-radiation effects, symptomatic relief in dry mouth disorders. So like this patient had a cut, as you can see, which was sutured outside because he kept a tin can over a firecracker and the lid blew off and it cut him, went through his cheek. So he had a fistula here. He had facial palsy because the nerve was cut and it was sutured. So what we did is we established the path, normal drainage path of the saliva. We stented that. We explored this wound. There were 2 facial branches, the temporal and the upper buccal, which were caught in sutures. We released them, and we have had a good result with this.
I operated him on 26th November.
Radioiodine, this is something which has come up in the last few years. Radioiodine treatment for malignancies of the thyroid is quite common. And you see radioiodine scans, generally the diagnostic scans, and you will see a lot of uptake in the salivary glands. You look at this salivary gland, this is it is avascular nearly with a lot of petechiae. It doesn't look healthy. And this patient, 7 years after his radioiodine, had a stone. So I had the occasion to go in and do the silendoscopy, remove the stone. But radioiodine does damage the duct, and a lot of dryness can be at least reduced if we do silendoscopy, regular silendoscopy with cleaning, removing of the damaged mucosa and dilating the strictures. Also, what else can we do? we can do like sometimes post-superficial parotidectomy sialoceles or fistulas, which can happen. So this patient had a cheek mass which was excised, just local excision. As you can see, this was the excision scar. He ends up with this scar, and then comes to me, this swelling, then he comes to me, and then we go in with the silendoscope. You can see the silendoscope has gone proximal to the swollen part, because that was the silocele. And we stented. As we come out, we put a guide wire, we stent this, and we keep the stent more in such cases. And on post of 45 days, you can see there's no abnormality seen.
This time.
So I'm aspirating that. Now this lady, interesting case, was conscious enough to undergo cheek liposuction. So you can imagine a patient who's that conscious ends up with this after cheek liposuction. So she was very furious. Fortunately, she was referred to me by a person who knew that I was doing silendoscopies, and this was the silocele which had formed. These are the MR silography pictures. This is how we dilate the papilla. Medial dilatation, larger dilators. And that's the scope going in. We go through the strictured part into the parotocoel. Generally, it is full of turbid fluid. Again, you can see I've gone proximal to the silocele. Once we empty the silocele, we have to find the proximal ductal system. That's a tough task, but you can see this duct, the proximal duct. We pass the guide wire into the proximal duct. Then this guide wire is used to railroad the stent. We are very sure that we are in the proximal ductal system, no doubt about it. And we are establishing the natural drainage pathway, so the silocele collapses over a period of time. So that was the proximal duct. This is the silocele. You can see the large size of the silocele as compared to the guide wire. That's scope into the proximal duct. That was the stricture close to the papilla, the rough edges. And that's the stent going over the guide wire. So it will go right up to the proximal duct system. That was the pre-op. That's the post-op. So now this patient underwent superficial parotidectomy at another place, ended up with this. So again, papilla dilatation. We have gone into the parotocoel. We find the proximal duct system. You can see this is a huge parotocoel. Compare it with the size of the guide wire. So we have to keep on exploring the parotocoel till we go into the proximal ductal system, as you can see here. That's the opening of the proximal duct. That's the stent. We suture it to the buccal mucosa. That was pre-op. This is post-op day 14. and post-op day 26. So if you ask me, I will say silendoscopy is nearly non-invasive. It's an organ preserving, it's a function preserving modality which gives us diagnosis as well as therapeutic possibilities for nearly all salivary gland obstructive disorders. It has low morbidity and has a definite cosmetic advantage. So has it met our expectations? And my answer is no, because it has exceeded our expectations. When we began this journey, we never thought we would be able to do such a huge variety of cases and we'll be able to preserve functioning organs. Something which... So my gratitudes to my father, my mother. She hailed from Baroda. My son and daughter, wife, my third son, Professor Francis Marshall, who is the father of silendoscopy. He is at Geneva. He is the one who taught me silendoscopy. You all must be knowing Professor Kirtane. He has been a big support. And without all these people, it would have been impossible. My OT staff, without whom it would have been impossible to embark on this journey. And these are a few of the things that I do. This is Karsubai, the highest peak in Maharashtra, with my son and daughter. This is Rajgarh. This is Brigu Lake with my wife. This is top of the mountains, the Austrian, our Austrian cycling expedition into the Alps. This is also from Salzburg. This is a place close to the border of Gujarat from Nasik. This is called Salota. I'm standing on the mountain, which is called Saler Fort. Thank you.
Thank you so much, Dr. Siris. Very exciting presentation. And I'm sure most of us would not have known these things if we had not listened to your talk. So can you switch on your video now?
Yeah, just a moment. Let me see.
So because we started late, we do not have much time for discussion, but I will start the ball rolling.
Yeah, you can start asking questions. I'm to start
in
the video.
In pediatrics, we do find recurrent parotitis, and most of the time, it is spontaneously resolving over a period of time. So we do get USG done, and if there is no stone, we don't proceed further. What is your take on that?
Yeah, see, in pediatric cases, there are recurrent episodes. Okay, so you can keep on treating these. This juvenile recurrent parotitis is self-limiting, but it tends to go away at the age of near puberty, like 14, 15. So if you see a 2-year-old child, a 3-year-old child, I will not ask him to stay with the symptoms for all these 8, 10 years. So what we do is we go in and do a silendoscopy. We dilate the stricture. We clean off the mucus plugs. And that gives them symptomatic relief. We are telling them that by doing this, we are going to give them symptomatic relief. We are not treating the cause of the juvenile recurrent parotitis, which is autoimmune.
Right. So you irrigate the glands, I mean, the duct?
Yeah. Endoscopy has to be done through irrigation. I mean, if you don't irrigate, the duct tends to be collapsed.
Okay.
And then we cannot see. So what we do is we'll also see the strictures. These juvenile recurrent parotitis patients will have strictures. So we dilate those strictures.
Okay. Another thing, you talked about tongue tie surgery leading to this complication. How often does it occur? Because people take it very lightly, actually.
Very lightly, yes. Yeah. It is not a very common occurrence, but sometimes if the surgeon is not precise, it can sometimes give rise to this fibrosis. They may not directly stitch the gland because now everybody is capable enough of doing a good surgery, but the fibrosis can extend and close off the papilla.
Okay.
So what happens is if there was no silendoscopy, we would have to excise that gland. And generally tongue tie is done in a patient in a pediatric age group. And then he would end up without a gland for his entire life. And a gland which was functioning, just because we didn't have the modus operandi to open the salivary flow back into the floor of mouth.
Right. And what is the minimum age in which you can do this silentoscopy?
I've done this in somebody who was just about to be turning 2.
Okay. Okay. So age is not a limitation, basically.
Age is not a limit, yes.
And what
Because
are the
we
common?
have a smaller scope for the pediatric age group, which is 0.75 millimeters.
Oh, as small as that. So, and what are the complications? You are dealing with a very delicate structure. So,
Correct.
are there any
Correct.
ruptures or bleeding or something like that?
Yeah. Bleeding is not such a big issue. It generally stops with irrigation. So we have never had to abandon a procedure because of bleeding. The thing which can happen is there are nerves around, especially in the submandibular. You have the lingual nerve. When you dissect, sometimes it can give rise to a lingual paresis for a little while. So these are things which can happen. Sometimes when we are dilating a stricture, you can intussuscept the duct.
Okay.
Or when you are pulling out a stone, you can deglove the duct. So these things can happen. If that happens, we generally tend to reintroduce the mucosal sleeve back in, pass in a guide wire, pass in a stent, telling the patient that this has happened. If it heals on this with these measures, it's fine. Otherwise, we are going to excise the gland at a later stage, not at this stage.
Okay. So over to others for any question, Dr. Jagdish Bhai or
Some of
anybody.
my video is not starting.
It's okay. It's okay. We would have allowed to see your face. But anyway.
Dr. Sirish, excellent presentation. In
Thank
fact,
you,
this
sir.
is a totally new thing. As a general surgeon, we used to remove submandibular stones by putting an incision inside the floor of mouth and preserve the gland. Rarely we remove the submandibular gland.
Right.
Yeah.
Now, what happens is if the stone is palpable, you can do that.
Yeah.
For stones
Yes.
which are causing symptoms when they are not palpable, what do we do?
Yeah. Right.
And we find when we go in, we find there are strictures. It's not just the stone, it's the relative diameter of the duct and the stone. So a 4 millimeter stone might not get stuck in a normal duct, but if the duct has a stricture, then the stone gets stuck there. So when we go in with the silentoscope, we dilate that stricture also.
Yeah.
So it gives us an additional security about, doing things with more vision, more surety. And I perfectly agree, when things were not available, you had to give relief to the patients. So you had to incise the floor of the mouth and remove it.
How costly is this equipment?
Yeah, the equipment is costly because none of it is made in India. We have now started having manufacturers making in India. The scope costs about, one scope costs about 6.5 lakh rupees. So you require at least 2 scopes, and the disposables are costly. The guide wire will be something like 2,000 to 3,000. The basket will range from 15,000 to 50,000, depending upon what kind of basket. Stents are now being manufactured in India.
Yeah.
We are moving because the economics is, the companies will always say we want volumes for us to reduce the price. So as this field picks up, it will become cheaper.
So talking about volume, series, how many ENT surgeons do silentoscopy in India?
In India, actively about 30.
Okay, good number.
Actively 30.
Yeah, recently there was a workshop in Bombay. I think one of the ENT surgeon attended that, and then he was proposing to have it in Baroda next winter.
Right.
So we were actively considering having a workshop in Baroda.
Fantastic.
Yeah.
You already have 2 people in Baroda doing silentoscopy, Dr. Hiren Soni and Dr. Dhaval Shah.
Okay.
Yeah.
So I've been going around teaching a lot of these techniques the world over. So I know a lot of people who are doing, and in difficult cases, sometimes I come over, sometimes the patients come over this side. So
you have really impressive volume. Very impressive volume of work.
Yes. And if you read his CV, Dr. Jagdish Bhai, if you read his CV, he is operating faculty at so many places, so many places, national as well as international.
Yeah. So maybe we should invite him to Baroda.
Yes, yes.
I'll come. The moment you invite me, I'll come. I love Baroda.
Okay.
Sursagar and the mix and Barf Ka Gola, Mangal Bazaar. I mean, they are all part of my.
Yeah.
Yeah, you seem to be very familiar with Baroda, that
Yes,
kind
yes.
of place that you are mentioning.
Right.
Great. So, friends, we end the session here. Thanks a lot, Dr. Siris, for a wonderful presentation.
Thank
And
you.
we hope to have some other talk in later part of our this series
Yes.
of lectures that we arrange every Saturday. And
Fantastic.
thank you very much for being with us. Thank you all for being with us. We meet next Saturday again. Thank you all. We